Okay. I might just start by showing you a video.
One thing that most emergency physicians probably wonder is how do all of their patients do as they move forward in life? Did they make the impacts that they wanted to? In the late 60s, there was a 2-year-old that arrives in the emergency department at St. Lawrence Hospital in Lansing. Not moving, not breathing, blue. His father was screaming for help. John Wittgenstein was on, but he'd never done surgical airway on a child before. He didn't really have any other options. He performed a emergency tracheotomy, and that's where I first met John. 17 years later, I introduced myself to him. I said, "You probably don't remember me, but you saved my life when I was 2 years old." I told him at that time I was applying to medical school and things were going well. When John passed away in 2004, I found this article that he had written about the emergence of emergency medicine. He kind of chronicled the story of me. I had finished my emergency medicine residency, which I did in Lansing, program that John started. As much as we try to separate our personal lives from our professional lives, for me, emergency medicine has been about both. To say that he had an impact on me would be an understatement. To this day, as I work in the emergency department, I'm still amazed that he was able to do what he did. I really wouldn't be here without him.
So that's a touching story. And it's kind of telling that someone who was on the receiving end of a tracheotomy grew up to become an emergency physician, and even then is still amazed that another emergency physician could do a pediatric tracheotomy. It's such a rare procedure that we don't train for or think about very often. But today we're going to cover how to do it, and we'll demonstrate it. Some of you may get a chance to practice it, depending on how many people are in the workshop. But just let that be a small warning to you. If you do go out and do this procedure and save someone's life, they may grow up and become an emergency physician. So keep that in mind. Who here has done or assisted with a surgical airway in an adult? So about half the room. Who here has done or assisted with a surgical airway in a child? One person. All right. So it's the exception to the rule. It's that rare. So even in a room of concentrated critical care experience where half the room's done surgical airways, it's rare to find someone who's done one in a child. And so there's not a lot of data out there. There's certainly no trials. There's very little case report data. What we do have is good animal models. And of course, we got guidelines of what to do in a can't intubate, can't oxygenate scenario. A lot of people look towards the UK Difficult Airway Society guidelines. But remember, our environment of pre-hospital and retrieval medicine, emergency medicine, critical care is not the operating theatre. So the situations we encounter are different from those that are theatre-based. If we take this reasonably recent guideline from the UK, they're talking about the younger child, 1 to 8 years of age. After trying a bunch of stuff, the first thing is attempt wake up if they're maintaining their SATs. Not an option for us. Then they're going to call for specialist ENT assistance in this patient who's got SATs less than 80. They're then calling for ENT. Okay, so we know how steep the oxygen hemoglobin dissociation curve is and how rapidly things drop in small children. And at that point, we're going to start to call for someone who may or may not come. And in our environment, they're definitely not coming. If ENT aren't around, they're advised to do a percutaneous cannula cricothyroidotomy or transtracheal jet ventilation, so a cannula technique. And if that fails, recommending a surgical technique, and they're saying surgical cricothyroidotomy. All right. So there's lots of points in this algorithm that I would argue either don't apply to us, or if we tried them, they would not work. So I'll cover why cricothyroidotomy won't work, even surgical in a young child, and why needle techniques won't work. Okay. And also, the Difficult Airway Society, these are anesthetists who've anesthetized someone and then find themselves in a can't intubate, can't oxygenate scenario. The whole situation there, clinically and mentally and philosophically, is different from us trying to resuscitate a patient that finds themselves in a can't intubate, can't oxygenate scenario from their disease. But what if we, through pre-hospital emergency anesthesia, put them in a situation with can't intubate, can't oxygenate? Maybe then we should use kind of anesthetic-y guidelines. Well, we have a system. We position people properly. We use adequate doses of neuromuscular blocker. We have a checklist. We have pre-oxygenation. We have apneic oxygenation. We have hemodynamic resuscitation prior to anesthesia. We have video laryngoscopy. We have a team-based approach. We have rigorous governance. We have recorded videos that we learn from. We have a salad technique for the pediatric drownings we go to. So we've also published data, including in the Annals of Emergency Medicine, on our success rates in pre-hospital pediatric rapid sequence intubation, with first-pass success rates that exceed those of in-hospital specialist pediatric emergency departments. So it's very unlikely that we're going to put ourselves in a can't intubate, can't oxygenate scenario. It's not impossible, but it's very unlikely. We're more likely to encounter a situation where the disease is causing the airway obstruction, not the clinicians. But anyway, we're going to learn a technique that will apply to this situation too. So what's going to cause airway obstruction or airway inaccessibility in infants and small children? I like to break it down into things that are inside the lumen, things that are compressing the lumen from the outside, and things that are actually a problem with the airway tissue itself. And we can think about pre-hospital or inter-hospital missions where we could encounter any of these particular scenarios shown in the slide. And of course, before slashing a little baby or small child's neck, it would be nice if we had alternative options to secure that airway before we go down the extreme final pathway of emergency front of neck access. So for example, with blood or vomitus or secretions, we need to be really good at our salad technique, our way of managing a contaminated airway. So half the workshop today is going to be focusing on clearing airways in infants and children. We should be expert at early management of burns, of the appropriate medical management of angioedema, of anaphylaxis, and so on. And then we should be thinking outside the box. So, this patient with a ball bearing sitting right over their airway with airway obstruction that we couldn't grab with McGill's, this team tilted the patient on their side and gravity just moved the ball bearing away from the airway. So, if we proceeded to emergency surgical front of neck access in that situation, we may have saved the child's life and we would have felt like heroes, but we would have missed the point. So if there's other ways of clearing an obstruction, we should think about it. Maybe we should think about carrying alternative devices for removing foreign bodies from airways. Maybe the appropriate forceps and scopes that can actually take us through the cords to remove foreign bodies. So these are all options we can think about. Of course, we've all learned the technique that if you've got a foreign body below the glottis that you can't extract, but you can push further down. Maybe you can push it into one main bronchus and ventilate the other lung. Maybe if it's vegetable matter, you can break it up with a bougie and push that down a main bronchus. But these are desperate measures, aren't they? But all things that we can think about. And remember, we're talking about emergency surgical airway, and we use the term CICO, can't intubate, can't oxygenate. But there are situations you can find yourself in where you can intubate, but can't oxygenate because the foreign body is distal to the tip of the ET tube. You've got a perfect 100% pogo grade 1 view of the cords. You intubate nicely. You connect end-tidal CO2 and the bag and the circuit, you squeeze, you can't shift any air through that tube. There's no end-tidal because it's completely obstructed below the tube. So maybe our terminology, Kaiko, isn't even appropriate for some situations. But as long as our mental model is, we have to go below this obstruction. We have to go transtracheally. We have to open the trachea. We have to establish an airway distal to the obstruction if we cannot shift the obstruction. It's about having the right mental model and the right approach, trying everything you can with this specific clinical situation you find yourselves in, thinking like clinicians, making a diagnosis and selecting the appropriate treatment rather than blindly following an algorithm that will lead you to an ineffective intervention and patient death. The NAP4 audit in the UK was a landmark study. Nothing had been done like it previously. This is 13 years ago now, I think. And one thing in airway complications they looked at, this was data from adults, was the high failure rate of emergency cannular cricothyroidotomy. Failed most of the time. Lots of mechanisms of failure, but in contrast, a surgical technique, even when performed for the first time by a non-surgeon who'd never done it before, was almost always successful. And NAP4 recommended all anaesthetists get trained in open surgical airway in adults, and that's happened. That's caused incredible change. But what about children? Where are the data? It's so hard, it's so rare. What can we extrapolate from? Well, animal models. Rabbits are a well-utilized animal model for infants and piglets for small children. This image is taken from a trip that Sarah Coombs in the picture and Carl and Ruby and I made to Minneapolis 12 years ago, I think, to learn infant tracheostomy amongst a bunch of other surgical procedures in a live animal lab. We learned a way of doing it there. It's not the way we've settled on today. But why not needles? Right, let's just go through why. Because a lot of us go through our training thinking, right, in an adult, I'm going to do an open one, but in a kid, I'm going to do a needle. And we've all got that mental model. And we've all got little bits of kits in our resus room of either proprietary devices or worse, oxygen tubing with three-way taps and cannulas that you put your finger on, thinking that's how we're going to save a baby's life. Why is that not going to work? Right, here's my son when he was 2-ish. That's him optimally positioned for intubation, ear to sternal notch. I did not intubate him. But what if we get into a can't intubate, can't oxygenate situation? You know, we're going to try and extend his neck. So that's the first problem. If you hyperextend a baby's neck, you'll flatten the airway. It's so compressible. So you don't want to hyperextend it. And then what we're going to do, we're going to get our needle and go in at 45 degrees through the cricothyroid membrane. Well, where's the cricothyroid membrane? The arrow is pointing to his suprasternal notch. So his trachea is above that. His cricothyroid membrane in a little kid is way up. It's much higher, much more cranial than in an older child or an adult. So we can't even go through the cricothyroid membrane. We can't access it. So we'll have to go through tracheal rings with our needle at 45 degrees. But we can't because his face is in the way. So you can't get a 45-degree angle, even in an extended neck, in a little baby or a small child. So you're going to end up going more vertically. The pediatric airway is floppy. The tracheal rings don't maintain the same stability when you push on the trachea that they do in an adult. So the force required to put a needle through the skin is more than the force required to completely compress that airway, which is why when the needle goes in, it comes out the back. So there's no guarantee that needle's going to go in the lumen. It's going to be exceptionally difficult to get a needle at that angle with the right force to stay in the lumen of that tiny little trachea. All right. What do our guidelines say, though? We're not working in theatre today, even for anaesthetists. This is pre-hospital retrieval medicine environment. What do the resuscitation guidelines say? Let's look at APLS. Right, this is from the 7th edition of the APLS manual in the UK, which came out earlier this year, or maybe last year, I think. Right. So is ENT expertise available? No, let's go down the right. It says open surgical airway, tracheotomy. Cricothyroidotomy only if the anatomy is palpable in older children. Great. So if you've got a big enough kid and you can feel the cricothyroid membrane, fill your boots, do a surgical cric. We've all trained for that. We've got great mental models for that. We've got the equipment for that. Brilliant. But if the kid is small, tracheotomy. That's in the UK APLS. Who does Australian APLS? Any instructors here? What do the Australian APLS guidelines say? Just before I go on to them, there's a little bit more in the UK guidelines in the text, in the procedures section. And they say there's a high risk of posterior wall puncture with needle techniques, so they should be avoided in children under 5. So contrary to what we've grown up thinking, they're saying needle techniques are contraindicated the younger you are, not indicated the younger you are. It says children up to 1 year of age should have an emergency surgical tracheotomy with direct visualization of the tracheal wall. You've got to see what you're cutting. We'll come back to that. Between the ages of 1 and 5, either surgical tracheotomy or cricothyroidotomy may be performed, but the latter only if the cricothyroid membrane can be confidently identified. Because the younger you are, the smaller that cricothyroid membrane goes, too small to put a tube through, and the more cranial in orientation, so it's under the mandible, hard to get to. All right. Older children and adolescents, needle cric is more achievable than in small children, but surgical techniques may have a higher success rate, etc. All right. Australian APLS guidelines. Most of you may have the app on your phone. You can look this up if you don't believe me. You go to the APLS guidelines, you go to the failed intubation checklist. Have a look at what it advises. On the left, as if you've got ENT, on the right, as if you don't. It says needle cricothyroidotomy. Great, that's what I thought I would do, but only in older children when the anatomy is palpable. And if that's unsuccessful, which is likely to be, an open surgical airway, tracheostomy. Cricothyroidotomy only if the anatomy is palpable in older children. So the Australian APLS guidelines on the app, on your phone, say if ENT aren't there, only do a needle in older children. Young children, they're saying tracheotomy. I don't know if anyone's teaching that on the APLS course. I haven't met anyone who teaches on the APLS course that has seen this on the app. So it's all there. We have permission. It's in the guidelines. We just got to figure out how to do it. What's the difference between adult and pediatric airways in terms of the procedure and the anatomy? Well, we know it's going to bleed. So in adults, we say it's not a visual procedure, it's a tactile procedure. Scalpel, finger, bougie tube. Put your finger in the airway, fill those tracheal rings from the inside, then you know you're in the right place. You won't create a false tract. Why are we not saying that in pediatrics? Well, because our fingers are bigger than these tiny airways. That's one reason. The other reason is it's very close, the trachea is very close to some important structures that you don't want to cut, like the carotid sheaths. And if you palpate an infant, floppy, moist, collapsible trachea, it feels like a collapsible, floppy, moist infant carotid sheath. So you can't really palpate the difference. You won't obviously palpate tracheal rings. You have to see them. So it's a visual technique. You cannot rely on your tactile senses. The adult airway is firm, pediatric airway is floppy, it's collapsible. So you have to see it to cut into it. Adult airway is big, so you can get a finger in. Pediatric airway is small, you can't get a finger in, but also the pediatric airway being small is much closer to the other important small structures. So maintaining midline is critical. As we've said before, it's uncommon to do an adult surgical airway, but a lot of us have done them. It's extremely rare to do a pediatric one. So no one's got a bunch of experience here other than pediatric ENT surgeons. And then adult, we all train for it. Everybody trains for it. Pediatrics, who trains for pediatric tracheotomy outside of pediatric ENT? No one I've met until now. So just a reminder of the anatomy. The airway's in the midline. There's big blood-filled structures either side of it. There's some important nerves and stuff. But the key thing I want you to appreciate there is that a nominate vein or brachiocephalic vein coming across. You've also got innominate arteries as well, but coming across on the, like above the sternal notch, you've got a big fat vessel there. So if you cut all the way down to sternal notch, there is a danger of cutting through a big vascular structure. So it's often recommended to do a large midline incision, but to stop just short of the final quarter of that space. Okay. Here's some other guidelines. These came out in the BJA, British Journal of Anesthesia, just very recently, early this year. And these are guidelines for airway management in neonates and infants, so under ones. And it says when tracheal intubation fails, oxygenate and ventilate via supraglottic or face mask. But if that's impossible, you can't restore spontaneous breathing, a surgical tracheostomy should be performed. So this is like beyond the relatively recent Difficult Airway Society guidelines. The BJA and I think European Society of Anesthesia produced this joint guideline. Surgical cricothyroidotomy and percutaneous needle cric are not suitable options in neonates and infants. For the former, because of the small size of the CTM, will likely render insertion of a tube impossible, and for the latter, because of the unfavorable anatomy. Okay, so I was talking about the difference between theatre-based anesthesia guidelines and APLS type guidelines, but now, certainly in the UK and Europe, theatre-based guidelines are recommending small babies, or babies and neonates, to do open tracheotomy, the anesthetic guidelines. So we're now faced with a situation where we've got guidelines telling us we should be doing this. So we have a training gap. How do we address that? The way we did this, where I work in the ED at Northern Beaches Hospital, is we asked a paediatric ENT surgeon to give us some teaching on it. And he went above and beyond. Dr. Seb Rangwis devised a little training model. His daughter wasn't too happy with what he did with her doll, but he got some materials from Bunnings and elsewhere.
It's about a centimetre and a half deep in an infant, okay? Yep. Yep, very good. Get your retractors in there. Open it up a little bit more. Yeah. Yep. Great job, Gareth. Good.
You're opening the retractors, is that?
Yeah, that's fine. It's really good. Cuff up. Yep, that's fine.
I say.
Perfect. So
it was more than just a model. There were lectures, and then we all got a chance to have a go or assist, and he kept reinforcing some really important points. The first one was maintaining midline is essential. If you lose the midline, you don't know where you are. There are obvious consequences to that. Really good lighting was important. Really good retraction was important, and really good suction was important. So you at least need 2 people for this. It's not a single person, single operator procedure. There's some physical logistics about who stands where that we've been working through, but he opened our eyes to the fact that you could devise a very simple training model and get some practical experience as close to reality as is affordable outside the pediatric ENT theatre. But the most important thing was he gave us permission, if you like. This was a specialist who does this for a living saying, I want you guys to do this if a child needs it and I'm not there. This is a patient-centered, not specialty-centered approach, which is so refreshing. We're still in touch with him, and he's been involved in every iteration of the training that we're presenting today. So at the beaches, we devised a quick reference guide, put it in our Halo trolley, and made sure the consultants are trained in that. We don't expect our registrars to do it. We've also got needle stuff in there because we'd rather somebody did something, and if they don't feel current or able to on the day, the needle stuff is there. We haven't thrown it in the bin. But the idea or the goal is for everyone who's in charge of resus to be confident that they could have a crack at this technique using the technique and the quick reference guide and the equipment. Okay, You mentioned that guideline. But we wanted to go a bit further. So we had a mannequin built, and it was quite expensive. Yeah, go ahead, Alex. Yeah.
In the example of the inhaled foreign body where you've got the tube down through the cords and you can't move air.
Yeah.
How do you get a sense of whether where you cut is going to be a bubble below said problem?
Yeah, well, I've thought about this a lot, obviously, for about a decade, but I've not done it. So take what I say with a pinch of salt. But the narrowest point of the pediatric airway is functionally, if not structurally, at the cricoid. So things will often lodge there. So if you're going at an accessible part of the trachea, you might be okay. But I guess if your trachea is going down and it's hitting obstruction, then you know where at least the top of that thing is.
And it follows that it would be a bad idea to push it further down if we're going to do this.
Potentially, yeah, unless it's something that's going to break up and go down a main bronchus. But again, how time critical is it? How much anoxia has this brain suffered? Do we need to do something right now?
Point of putting it in CT, you might penetrate it. Things like below it.
Exactly. Depends what it is, doesn't it? I think, the commonest things described in the literature are things like cocktail sausages, lollies. It's often food or plastic toys. Ball bearings are common kind of stuff. Lolly wrappers, yeah. As an aside, there was a case report of the child of an emergency physician who started choking in McDonald's. And I'm sure there were several learning points there, but and became apneic. It obviously had airway obstruction. They did the back slaps, they did the chest thrusts, nothing worked. So the emergency physician put his face over the child's mouth and nose and sucked as hard as he could. And the child had inhaled one of those plastic ketchup wrappers or containers or a part of it and ended up in the mouth of the ED physician. The kid started breathing and did fine. So they wrote a case report. So that's what I'm saying. There's other options than cutting the neck. It's got to be.
The suction thing up there, did you talk about that? Suction one?
No, is that the rescue vac? I've forgotten what it's called already, but I've got one of those at home. They're a bit big to go in our bags, but yeah, there are other options for foreign body removal. Yeah, including what ENT would do, which would get some kind of rigid scope, go through the larynx and use some grasping forceps and pull it back. And I've got that stuff we can play with today as well. All right. So this guy is called Hemsworth. He was named by the person who made him, Emma, who is a paramedic, but also a genius at moulage and simulation and mannequin and silicon molding and 3D printing and anatomical reconstruction. And this was the prototype. And it took her 11 months to make him, which is longer than a real baby. So he's very precious. And he's got replaceable neck parts with good tracheal and vascular anatomy. And we got version 1. We got Seb Rangwis, the ENT surgeon, to operate on him to give feedback. We got version 2. Then Nat and I did 10 tracheotomies at least on version 2 to try and hone the procedure that Seb had taught us. And we already, within the first couple of iterations, we were thinking some things are going to work better than others in the retrieval environment with 2 operators. So we just started to modify things a bit. And then this came out, a randomized controlled trial of different tracheotomy techniques in a rabbit model. It's a really, really sweet paper. And in the supplementary material, they provide videos of both techniques. But they found doing a technique over a bougie more effective than a technique that resembled more closely the one that we'd been practicing. So we went for the next iteration. And we realized we needed a CCP brain in all of this. So Jacob, who's here and helping with the workshop today, and me and Nat and Luca, who's up there, our medical student, elective dude who has extensive airway teaching and management experience and is also a paramedic. The four of us spent a morning doing about another 10. And again, honing where we go, where we stand, where we put the procedure, and how we take things forward from there. So I'm going to show this video, but I'm going to describe some important features first so you can look out for them. And then we'll do it in the workshop later. So we've tried different ways of where we stand, and we think the assistant should stand at the head end, and we think the operator should stand on the side of the patient that corresponds to their own dominant hand. So that's me. I'm right-handed, so I'm on the patient's right. Nat prefers to cut with her left, so she would be standing on the other side of the baby on the left. So we stand on the side of our dominant arm. When we place equipment where it's going to go, the suction needs to be reached by both the operator and assistant. So when we start to cut, the operator is going to be pinning the tissues down with one hand and cutting with the other hand. So they can't operate the suction, their two hands are engaged. The assistant is going to be at the top end, they can manage the suction. At some point, both the assistant's hands are going to be holding retractors. So then the operator needs to be able to reach the suction. So we both need to get to it. Things like BVM, capnograph, catheter mount, HME will be at the top end. Equipment that we're going to be using as the operator are going to be at the patient's feet or beyond the patient's feet on the stretcher so we can easily reach them. We will go through a checklist, and that will include ensuring we've maintained midline. And sometimes people recommend actually getting a Sharpie and drawing on the chin and a sternal notch so you can line those up. Other people recommend sandbags either side of the head. Some people in the UK on a course I went on put brown tape, put it under the chin, tape it to the bed. You don't want the head wobble during this. Midline, 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 suction, 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 good light. And the best light is your own head torches. Maintaining midline, getting the strap muscles either side. So you're cutting through skin, subcutaneous tissue, and you're trying to get trachea, and you'll recognize trachea because of tracheal rings. There is a danger with retraction that you retract asymmetrically, and you think you've got midline, but you're not in the midline. So slowing down, slow is smooth, smooth is fast, that concept, you don't want to rush this. Time is of the essence. Time is brain, but rushing is going to slice a carotid artery. So slow it down. How quickly should it be done? Well, it depends, doesn't it? You might be getting SATs in the 80s through the eye gel, but not sufficient to safely transport this child, and you need a definitive airway, but you've got time. Or there might be complete foreign body airway obstruction that you've been unable to move, and this patient's been anoxic for 2 minutes and is bradyasystolic. Then you want to get it done in a minute, but you don't want to rush it. So Nat does it in about a minute. The one you're going to watch here, I think I do it in about a minute and a half, going slowly.
All right, so we have light, we have suction, we have scalpels, retractors, tubes, and total CO2 and a BVM. We've positioned the patient with the neck extended. We've identified the midline. Midline is marked back. We're going to make a vertical skin incision. Spreading my fingers, suction. More practice it. Rings probably gone through the thyroid there. There's some tracheal rings there. Yeah, it's lovely. Okay. Again, tracheal. Bougie. That's it.
Tube Fuji. Practice most tubes in. Tubes in, not too far. BDM's out. I'm going to inflate the cuff. Squeeze. Chest rise and excited.
Okay, incidentally, Jacob and Luca did one after Nat and I had a go, and that was their first ever, and it was smoother and faster than either of us, but the video is not as good. Otherwise, I'd have shown you their video. Any questions or comments on that?